Hello friends, it is 1 minute before happy hour, I guess, on the East Coast and before 3 here on the West Coast. We will start promptly at 3. All right, Erin, just want to make sure we don't have a waiting room, do we? Nope. Okay.
No, we don't. We're good.
No, we don't. Okay. All right. Good evening and welcome to AMDA COVID Grand Rounds, pearls from your colleagues, and happy hour on the East Coast. I'm Sabine von Price-Friedman from the Washington AMDA chapter, your host. And in this second peer-to-peer discussion, we aim to capture what you and your colleagues have learned the hard way. We also want to identify and highlight controversies, best practices, and data that is helpful managing our patients' particular needs. This is an interactive discussion and we encourage you to use the chat function. Chat is your friend and also a tool for us to ensure that we get the questions that are most specific to you. Topics of greatest interest change. As we move through the progression of the COVID pandemic, different issues arise to the surface. We have now figured out some solutions along the way that work, such as generalized masking, social distancing, and isolation. But all of these solutions come at a price. As the country is becoming weary, people, including the families of our patients and residents, are starting to question these solutions and they wonder, is the price we are paying too high? And in fact, our infection control measures are taking a toll, even as they give us the gift of protection from the virus. We have seen a surge of loneliness, depression, and failure to thrive in our lockdown facilities. Today, we will talk about this from several different perspectives. CMS guidance. CMS has released a memo in regards to nursing home reopening recommendations. Then, how do we balance our patients' and families' needs against the need to control the spread of this virus? And finally, how do we combat the toll our infection control measures are taking on our patients? If you come up with any other questions related to this topic, but even not related to the topic, and we have time to discuss it, just put it in the chat box, and we have this unique opportunities of having 3 distinguished AMDA peers and leaders to share what they have learned. So feel free to ask away. Today with us is Alex Bartek. He probably doesn't need an introduction. He is Director of Public Policy and Advocacy at AMDA and extremely familiar with regulations that affect us as medical professionals in the post-acute and long-term care space. He is a strong advocate for our patients, our communities, and us. Dr. Richard Pfeiffer is a return presenter. He is the president of Genesis Physician Services and chief medical officer at Genesis Healthcare. He leads a team of over 550 clinicians who provide care for many Genesis patients. And new to us today is Jessica Callender-Rich. Welcome, Jessica. She's a geriatrician and post-acute medical director for the University of Kansas Health System. She's a medical director for 2 fertility facilities in the health system's preferred provider network and sees patients there. More recently, she is the chair of a regional task force in COVID-19 for LTCs spanning the Kansas site of Kansas City. In this role, she's performing on-site infection prevention and control assessment surveys to help prevent and mitigate the spread of COVID-19. Welcome, everyone. Before we get started and into the meat of the matter, let's do our first poll. And Eric, what is your perspective on the May 18th CMS guidance on reopening nursing homes during the pandemic? Eager to move forward, proceeding carefully and deliberately, following the steps toward reopening as described by CMS, or worried about moving too quickly and anticipating a very slow path towards nursing home reopening? Go ahead, click and vote. Are you able to vote? We are not able to vote here. I hope the voting is going on. Ah, that's better. Okay. Great. I think the vote is out. Nobody's eager to move forward. I think that is something that I expected, and I didn't vote, but I certainly wouldn't have voted for that. And then the remainder is carefully and deliberately, or worried about moving too quickly. So I think that sort of probably reflects all our trauma that but more importantly, our facilities and our patients have gone through in this COVID crisis, where we have become the epicenter of the epidemic and lost so many patients. So, Alex, let's start out with you. What is the guidance contained in the memo?
Yeah, thank you, and thank you all for joining. I like the introduction. Extremely familiar with regulations. There's not many good things, if any, about the pandemic, but one good thing is I have a lot more hair to pull out now, and when I do, it's not very noticeable. So I can keep doing that with all these new regs that have come out. And just so we level set, just so we're talking from the same playbook here, the memo that is being addressed here is the May 18th, 2020 memo that came out from CMS in regards to reopening. First of all, I would urge all of you to read it if you have not. If you haven't heard that they released a memo, please do go ahead and read through it. They actually, oh, thank you. That's
very helpful.
That's the old school screen share. I'll just hold it up to the camera. Anyway, so please do go ahead and read the guidance. You can print it out and make sure others have it as well. But in essence, what it means is I think reflective of what we just saw in the survey, and that is that CMS, and I'll give them credit, they consulted with AMDA and other stakeholders, Leading Age, ACA, and others, as you can imagine, before they issued this and asked us to do that, and we provided our input. We were happy to see that a lot of what we said was in there, and that is to take a very cautious approach, and that it's only, in the sort of the last of the phases. They outline certain steps. They actually have 5 bullet points here of what steps nursing homes should be taking before reopening. They do recommend that visitation be not allowed or is severely limited. And even in phase 3, so the last phase, when you do open for visitation, that there is proper screening protocols, and then there's testing and other things. So I think there's a lot of steps that need to happen. I will tell you that there was a question. I was on a CMS call the other day. Can't tell you which one, there's so many. But one of the people actually asked an interesting question, which was, they're getting obviously a lot of pressure from families. They're seeing the states reopen. They're seeing, sort of almost spring break type parties, if there are coastal resorts or even lakes or whatever. And of course that begs the question, why can't I go see my mother or my grandmother, or, who's been isolated and may or may not be doing well? And I think it's a great question. And, people are legitimately wondering about that. And one of the questions was, well, what if we do that outside? What if, we do it safely, social distance, and, we kind of see them outside. And CMS actually wasn't all that ready for that type of question, because all it kind of addressed was somebody coming into the building and all of that. But I think it exposes, even doing that exposes to a certain degree of risk. And I think, the physicians on the phone will probably address that. But I think, people are really ready to see their loved ones in nursing homes, but CMS is holding steady along with the same as AMDA recommendations, not yet. Be very, very careful as you're phasing it in. And, the other problem is funding to make sure that we have the testing, the PPE for everybody. All of this is going to take some funding.
Let me interrupt you there for a minute. So can you walk us through the phases that they have outlined there? I think that would be instructive for our viewers. So there's 3 phases, as you said, and they correspond really to the phases of where the disease is at, correct?
Yeah, and they do recognize that, obviously a lot of nursing home cases have been where there's community spread. So, phase 1 is visitation is generally prohibited, except for, compassionate care situations, which are very, very limited, and you have to have screening and additional precautions, even in those situations. Phase 2, the visitation would be still generally prohibited, but again, in these compassionate care situations, there's not much difference even in phase 2, but, and you still would be screened, and additional precautions would be taken, including social distancing and hand hygiene. They would still require that all visitors would wear a cloth or face mask of some sort during their visit. And, in phase 3, visitation is sort of the last point that I was making, was the visitation would be allowed, but you would still have to have screening and additional precautions, again, with social distancing and hygiene. So, even in these phases, it's very sort of narrow, I would say. And that's, recognition that this is a very vulnerable population. And, if you get a case, even in a facility that hadn't had them up until now, you're still just as susceptible to it as every other facility that has had them.
So it really provides for moving back and forth too. I mean, first of all, you have to move through each phase first, right?
Yeah,
and then if you fail at one phase, you're going back to square one.
Yeah, and I haven't seen that the state's really going back. I think there's other factors involved with anybody who we'll see how it all goes, but I haven't seen any state or locality go from phase 2 back to phase 1. I think that would come with a lot of tough decisions. But certainly, the other problem with this is it's not statewide. We've seen, I know in Maryland, for example, although the governor declared which phase we're in, counties can then go in and say, well, we're still in phase 1. So even though the state may be saying certain things, the county may be doing it. So for anybody that's, and Dr. Pfeiffer probably, I'm sure will talk about it, for anybody with change, trying to figure out where they are, it's hard to develop uniform policies because states and even localities are in very different situations.
Yeah, that is a good segue. Rich, how, as a CMO, how this is applied to your facilities? Have you done anything in response to this memo?
It's a tough situation that we have right now. And, I'll acknowledge, I drafted that polling question, knowing full well, as you did, that attendees of an AMDA call like we had, we'd be voting for options 2 and 3, right? Because we're going to be conservative. We're thinking about patient safety. And it'd be very unlikely that one of us would vote eager to move forward as fast as possible. The reason why I'm raising this now is that a lot of the other stakeholders out there are, in fact, eager to move forward as fast as possible. And there's some dissonance between us, the medical community in post-acute and long-term care, and those other stakeholders like patients and families. Many of them want to move forward as fast as possible because they've felt extreme duress at not having visitation and all the other things that go with having some freedoms. Politicians are getting pressured to move as fast as possible, and that political pressure is a big deal. Regulators, surveyors, ombudsmen, we're seeing survey tags now that seem to make no sense because the CMS guidance from March 23rd still holds around restrictions, room visitation. room restrictions, visitation, those are all still in place. And CMS, and I don't know if anybody from CMS is listening to this webinar, but CMS hasn't been entirely clear on these issues and hasn't retracted the March 23rd guidance, while at the same time has sort of implied that it's okay to move forward in certain ways. So it's been confusing. So then to answer your question, how are we handling it as a large chain in multiple states, is that we're really frustrated because there's lack of clarity. There's a framework that, as Alex said, that's being provided to the states. Some states are embracing it and trying to figure it out, although they haven't yet. Some are passing it on to the counties, saying, counties, you work it out. And other states are saying, well, we'll just sort of leave it up to each nursing home to decide for themselves. And I have great angst about that. In the very early days of the pandemic, we tried creating our own policies before CMS even came out with theirs around visitation restrictions, just in the interest of safety. And we tried basing it upon our understanding of where there was community prevalence and community spread. And that information wasn't readily accessible. And it still isn't. We do need our public health officials to guide us as to where it's safe and where it's not to take these steps. And I hope all states and county officials are going to embrace that as their responsibility to give us the guidance we need.
Yeah, I think you make a very good point, especially in the beginning of the epidemic. We didn't really know. It was always hush hush, who has it, who doesn't, you know, how bad is it really out there, and how do we really assess whom to borrow from our facilities? So kind of a bit of the Wild West. And speaking of that, I think, Jessica, you have developed a model that gives maybe your facility a platform from which to make an assessment. And I'd love for you to talk a little bit about your work in that regard.
Yeah, so you give me too much credit. I didn't develop the model. I took the model, and what we have done is take the CDC infection prevention control assessment tool and use it to go actually into facilities and apply the tool. So initially we rolled out this survey tool that was created, and at least in my state of Kansas, they are, CDC is doing some calls to randomly sampled facilities in the state. And when a representative came to one of the counties that I have been working with, we actually walked through ways this could be used on site. And so in Johnson and Wyandotte County, which are the Kansas cited counties of Kansas City, we are going into sort of one by one every facility that has positive cases in order to do on-site assessments with their leadership staff. And in it, we run through all of the pieces of resident education and prevention, staff education and prevention, what their testing plan is. We walk through the whole facility and look at their layout. We have found times where we could help kind of guide, you know, as an outsider looking in, there's certainly a different perspective on maybe the COVID unit can be here rather than here, and a fresh set of eyes. On top of which, we are finding that the facilities, while we are all reading the same guidance, some of them are interpreting it in a totally different way.
No way.
And so the counties I'm in didn't actually know that until they started coming along with me on these. And so they couldn't understand why they were having so many challenges helping facilities, because like you all know, like they don't know the facilities like we do. They don't even really know what a long-term care facility looks like or functions like or is. So it's been a really actually amazing tool to use. And the key, when we have found, is to walk to call in advance. So it's not like a survey, right? This is not a state or CMS survey where everybody runs and panics and hides their, you know, dirty laundry. This is, we go in and we introduce ourselves as there to help, and then we fill out this great PDF and we send them recommendations later, and then they have communication with us kind of ongoing, with me as this random contracted person who represents no one for the county. But then I can turn to the county for help if needed, and I have definitely no coordination with the survey process. So I'm like a safe person to do this.
I think that's very important. Well, thank you for the work you're doing. What are issues that you're seeing in a facility, and what would concern you in the frame? We're talking about the 18th of May memo. What concerns do you have looking at having now had a chance to look at quite a few facilities and seeing what they're actually doing, or how they actually interpreting the guidance? What are you seeing, and what about that encourages you or worries you about facilities moving through different phases?
Yeah, I think we can all agree that access to PPE is critical for any sort of moving forward process. And a big question that raises for me is whether that means access to PPE under crisis standards or access to PPE under normal time standards. Mm-hmm. Because, you know, if we're going to question whether or not they have access now, and we know that they are using a gown, you know, all day, and the same person is putting it on and taking it off and exposing themselves potentially while doing this very, I think it's almost like rocket science to do that without, you know, contaminating something. If that is our benchmark for having enough PPE, then I think probably more thought needs to go into our plan. And so this you know, adequate PPE to me is kind of the most vague and frankly terrifying plan.
So yeah, can I comment on that?
Yes, please go ahead, Rich.
So that's such a great, important point, Jessica. Yeah. And for those of you, just as I do, I'll screen share too. And you're holding your May 18th document, right? Turn to page 3, because on page 3 of the document, it specifically talks about access to enough PPE in order to even proceed down this path to reopening. And it specifically says crisis capacity strategies are not acceptable. So then if we turn to the document that defines what do we mean by crisis capacity strategies, reuse and extended use are crisis capacity strategies. So if we're doing anything around gown reuse and extended use, and I bet you a lot of us are, because there's a global gown shortage, technically nobody's prepared to proceed down this path right now.
And you read that document, and I read that document, and you can bet that almost no one who's making some of these decisions, if it's being made at a facility level, is reading that document that closely.
Right? Yes, you have to read it closely, but that's what it says.
Yeah.
Yeah, and this is Alex. I mean, we have to remember that it is sort of guidance, right? You know, and not only that, you serve on a COVID task force, and you mentioned politicians. They're not necessarily reading this document or understanding what it means either, right? So there's a lot of like, yeah, but what can you do to, you know, to help us? So it becomes this sort of give and take. But I agree that, and the other thing is that I would say that not only is it sort of a short-term thing in nursing homes, one of the things that we've been pointing out on a federal level and to members of Congress and CMS, this is a long-term thing. Like, you know, I mean, this is not going to go away. You're still going to be sort of worried about COVID coming into facilities for the foreseeable future. And even more so in the fall when influenza and COVID potentially hit the facilities. So one of the things that, you know, we saw President Trump hold a briefing about the Older Americans Month in May, talking about that they're going to send PPE for, you know, all facilities. And they said something like enough for 2 weeks. And, you know, the reaction to that was, okay, and what do we do after that, right? So I think that the other part of it is that people need to understand that this isn't sort of this short-term thing. This is going to be a marathon, unfortunately.
I think we've heard that a lot. I think maybe this is now time to do our second poll, Aaron. And we'll continue the conversation afterward. What is your greatest challenge in COVID-19 prevention for your facilities now? Speaking of marathon. All right, would be. Oh, look at that. See it. This is really fascinating. That could be a little article in and of itself. Adequate PPE supply. 61% of our listeners, adequate PPE supply. So it really shows that we are not in non-crisis conditions. I take that, bring that back up, Erin, if you would. Staff adherence to PPE, I certainly see that. Interesting, because I think people, especially as far as the face covering is concerned, it's not so much the mask, but the face shields. People are getting quite tired of that. And as summer comes around, I think we will probably see less and less enthusiasm for this intervention. And interestingly, resident family unwillingness to adhere to infection control is third, but it's still a fairly substantial amount of you have said that that is a concern. And having said that, what can we do? I mean, there is a reality to the isolation syndromes, the failure to thrive, the loneliness, the actual suffering. And is this too high a price to pay? And what about, I'd love to pick all of your brains really, what alternatives have you imagined or even seen so that there is some contact? And how do you see the way forward? Or are we not going to be able to see our mothers and fathers for the rest of the year? Is that really what's going to happen? Or is there a way to make it safe and possible at the same time? Which, what are you thinking?
Well,
since you were right the first time, so.
I don't know if right or wrong, it's an opinion. But actually, there were two questions that you asked, and I want to comment on both of them, right? One is around the questions, and if I could just comment on that for a second, the response to the polling question. I was a little surprised that so few of our respondents chose staff adherence. And I think we all overestimate how adherent our staff are. And I think we all need to actually question it more. And one of the things that we started doing in our organization, it started just a little bit here and there. We started dropping in on our centers virtually, using video conferencing, using an iPad, because now we have all these iPads around, don't we? So many of us do, for family members and residents to visit, for telemedicine. Well, they're not always in use. So we started using iPads for virtual infection prevention rounds, to pop in and have someone walk around the hall at the instruction of the person somewhere else who wants to just drop in and see how we're doing. And it's like kind of a spontaneous visit from a survey or something, like an unannounced visit. We do an unannounced virtual IP rounds, and it could be any shift, any time during the day or night. And the person who's doing the rounds is going to be looking through that video conferencing to see how staff are doing. We are finding adherence gaps that we didn't think existed, and we're able to educate and address and close them. So I just had to comment on that based upon the survey question.
Thank you for doing that. I have observed that, and I just kind of looked around me and I'm like, where are all the face masks? Nowhere. On the nurses station somewhere. So you got to go over and over.
And you got to wonder, what's happening at 10 at night? What's happening? Yeah. What's happening after hours? And you know, the virus doesn't care what time of day it is; it's going to spread.
And you know, and that is so scary to me when you talk about reopening, right? I mean, reopening in a way depends also that we're doing the internal stuff really, really well, right? So if that's sort of, you know, not fully executed, you know, that makes it. We are humans, and I think Swati Gawa said, you know, because we're humans, our infection control measures will eventually fail at somewhere. There will always be holes. Yeah.
Right on. Right. So, so the second part of your question then was about visitation. That I could go there. But
yeah.
I'm sorry,
what can we do?
Yeah, I was just gonna add that I think I agree with you that I was somewhat surprised by that. And I will tell you that I got a phone call the other day from one of your colleagues in another state late at night, and he was distraught, particularly because a surveyor came in and noticed, this facility was doing quite well. This person was dealing with a COVID negative patient because they had already been tested. It was a unit where people had been tested and came from the hot test and tested, but they cited an IJ for failure to wear a gown. And this was, one of those strike team, I'm not exactly sure where they're still trying to get to the bottom of it. Of course, the question that was asked of me is, what can they do? This is a great, this is a good facility. Obviously, even doing everything right, as you mentioned, 10 o'clock at night, long shifts, there are going to be gaps, and particularly if you're on a unit that you are fairly certain or, whatever. But, I don't know, nursing homes are right now under great scrutiny from the politicians and whatever. I don't think that's happening to that degree. And in fact, I asked my wife, I said, would this have happened in the hospital at short shock trauma here in Maryland? She said, no, I don't think that they would come in and just randomly look. But, nursing homes right now are under great pressure because of the death rate, and, they're sort of getting the quote unquote the blame for what's holding quote unquote everything up, I think, to some degree in some areas.
Well, we can't stop being, right? We can't just stop doing surgery, and we're there. We cannot close like the schools, kindergartens. We can't do it. We are there. Rich, did you want to say a little bit more about what we can do? I want to hear your thoughts.
So here's what we can do. And yeah. Alex, you surprised me during the beginning of the call when you referenced outdoor visitation and said something like CMS is still hedging on it, because just today, ACA issued an announcement and some guidance. And can I share my screen? Would that be okay? That's like going way off script, but I got it right on. I can try, right?
I think you have a share screen option.
I'm going to do it. I'm going to share my screen and show everyone what I'm talking about.
Do it.
This is an ACA document that I was surprised to see this morning about keeping people connected. It's dated today, May 28th, and it says, use outdoor spaces. The use of outdoor spaces are not prohibited by current CMS guidance on the restriction of visitors and can be done now and are an optimal spot to have residents and patients and families spread out to connect, et cetera, et cetera. So I'm not sure if CMS saw this before it went out. I'm not sure, Alex, if AMDA did, but it got a lot of people's attention. So we're actually looking at that right now. And just in the hour before this call, I was meeting with our chief nursing officer and chief operating officer to spec out what would need to be the case, what would need to be true in order for us to start doing outdoor visitation, which we haven't done yet, but actually we'd like to be able to do. And we came up with probably 8 or so things that we need to put in place to have that happen. And we're going to try really hard to do that.
I like it. I like the yes, we can attitude, but always thinking, yes, we can, but we want to make it safe. Jessica, what are your thoughts on alternatives, ideas? What have you done in your facilities?
Sorry, of course my phone is going to ring for 1 second. There we go. Okay. Sorry. The outdoor thing, actually, we have tried. We've done it for some interesting, like I had one resident whose wife was his neighbor in the facility. Wife went to the hospital and died from an underlying other non-COVID related malignancy. And the daughter felt like she needed to be in person to tell her very frail father that his wife had died. And so we actually have one of our buildings has a rooftop patio area that they've always used for activities. And so we had them both go upstairs. We attempted to socially distance them. I mean, she was there telling him that his wife had died, so it was not going to be 100% successful. Plus, he had already been COVID positive, by the way. But, we implemented the screening and a lot of restrictions, and we felt like it was almost a compassionate care situation. But I can certainly see times outside of that where if you could use a lot of the social distancing stipulations that we have already talked about and implemented perhaps in our regular lives and create spaces that they could happen in outside, not in, but on the property of facilities, it does feel like a really good alternative, unless you live in a very four-season area like mine, where it's going to be 100 million degrees soon. That being said, I think that a lot of people have moved towards doing things like window visits. Those are okay. Sometimes I think, depending on how the facility is set up, they feel a little bit like prison. But they're okay when framed well. And I've also, of course, there's FaceTime and Skype and all those things. I've had a lot of people with dementia tell me they feel like someone's going to think they're crazy if they talk into a portrait. So more than one person has told me that. But I mean, all of the things that we're doing are all going, we can use all of those platforms moving forward. The moving forward piece is about how we can be creative. So if we have a safe outdoor space, which some facilities are going to have, that's great. I think that creates a huge challenge for our urban facilities that don't necessarily have a space like that. I mean, I'm lucky that my very urban facility has a rooftop. But a lot of places aren't going to have that in our larger cities. And that actually presents a whole nother challenge.
But then you can get creative too. So maybe it's just one visit a day, and maybe it's in the parking lot.
Sure.
I think you gotta you have to become creative and make do. I've seen beautiful expressions of love and connectedness. For example, one of my patients had a birthday, and her son, and that's a very urban facility. I mean, there's only parking spaces around it, and her son played the saxophone under her window, and it was amazing. So think about other ways of connectedness. I think, and and the beauty of that was, all the residents really enjoyed it, and they were able to take part in a way that connected them beautifully. So there are other ways to connect. There are ways to come to think of a safe way, and maybe not for everyone all the time, but I think those are things that I have seen. Another one, I think we're talking about opening up the facility to outside, but what about, shouldn't we start inside the facility too? I mean, isn't it, before we even talk about outsiders coming in, what about inside? Have you made any changes there, or have you tried to be creative in keeping it safe yet more social? Because many of our folks really depend on that social interactions. I can tell you about one thing, but I want to hear what you guys have done.
Jessica, do you want to comment first?
Do you have anything?
Yeah. Oh, I mean, I can. I was going to let you go ahead. It's all good.
Go ahead, talk, Jessica.
I think every building is set up differently to do different things that are creative, right? And I will say, in my mind, the most important thing about that creativity piece is knowing that the staff is on board with anything that you're trying and will help support your ability to do it. Because if we are trying to do things to get people together, and then we walk away, and like was discussed a little bit earlier, they pull their mask down or whatever, then we have run a risk, meaning the staff pull their mask down. We have sort of run some risks. But I do think, as much as these infection prevention assessments that we're doing are really asking things like, are you doing hallway bingo? And you probably shouldn't be. As part of that tool, I think that us as clinicians in the facilities recognize that some of those things are really critical to prevent functional and cognitive decline. So we have taken groups up again onto the roof, because I really do feel like outdoors is the safest.
Outdoors is good.
Right. We have certainly we've tried to cohort units and let the people in the units be in the same room, very spaced out, to do activities, but in a way that, if something were to happen, at least they would all be within the same unit with the same staff around them.
Mhm.
And again, only certain facilities can really do that. And, we've gotten really good at cleaning bingo chips because it turns out that they can actually be cleaned, although I don't think in the past they ever were.
Or you can post that recipe on the AMDA COVID resource website, please. So, Rich, what have you guys done? And then I also want to get to, tell me what you have done, and then I want to get to a messaging question.
Yeah, maybe less about what we've done and more about where we're pivoting next, because up until now, we've been extremely cautious, perhaps because of our geographic concentration in the hotspot states. We've been pretty significantly affected by some very bad outbreaks. And so we've been very careful and very adherent across our whole system at the whole issue of room restriction and avoiding group activities or any such things. And we pretty much stuck by that, even though it's been extremely difficult. We've done what we can to engage residents in their rooms, but actually have not pulled them together. And now, as we look at things, and we've gotten far better at unit level cohorting. Unlike the way it was 2 months ago, we now have units and subunits as fully functioning entities with dedicated staff, dedicated equipment, where folks are not going back and forth. Now that we're doing that more effectively than we ever could have before, it required a totally different view of staffing. Now we're looking at liberalizing those restrictions, and also, not as the primary reason why, but now CMS appears to be giving guidance that permits doing so, because up until now, frankly, it's not been consistent with the guidance that they've given surveyors. And so anyone who has been doing group gatherings, communal dining was liberalized, but has been taking a risk, a survey risk. But what we're looking at doing now is to liberalize, but to do so at a unit or subunit level, so that we'll still not mix residents for any reason across units or subunits. So just like the holds of the Titanic or any big shipping vessel, right? The holds are separate so that if a leak develops in one, it doesn't spread to the next. We're operating our facilities the same way.
Yeah, well, except this Titanic, that didn't work.
I know, we don't want it to sink. So
that was a terrible example.
Terrible example, but you know what I mean. We want the holds to keep the compartments separate.
Yeah. Yes, I think that's a very good point. I want to go back to something you said, Alex, and that was, it's a guidance. Wait, what do you say?
Right. Guidance versus a requirement? What's the difference? I like that.
Yeah, I was just like, wait a minute, what? Guidance means we don't have to adhere to it? Or?
Oh, I think, no. I don't want that to be misinterpreted in any way. I think any CMS document that comes out, particularly, I would say if it's included in like an interim final rule, that has a certain level of enforcement. Other things have other levels of enforcement. I go back to like CDC guidance about, 2 negative tests before they're transferred. We saw how well they adhered to that. So that was my only point, is that I think states and localities will make their own decisions. The discussion you just had, for example, about urban and other areas, there's been a lot of pressure on areas where COVID hasn't been as prevalent and has not been in facilities to open it up more so than it has been in New York City and New Jersey, understanding that those areas were far more, harder hit. And it goes back to, I think, what Rich said at the outset. Medical professionals are constantly and consistently concerned about it entering at any point, no matter where you are in the country. Whereas others are looking at it and saying, wait a minute, well, Rich probably could comment, somebody on the Eastern Shore of Maryland is very different from the DC area. So the Eastern Shore has very different thought processes, political leanings, and all kinds of things. So that's what I mean about, guidance being interpreted. And I think Jessica talked about it being interpreted in different ways. And if it's not, ROP, requirements of participation, or an interim final rule, I think it has different levels of enforcement. I'm not saying that, just feel free to ignore it, because you could have surveyors come in and say, here was the guidance, and you didn't adhere to it. So, I think, as Dr. Nace has said it 100 times, you know, you're building the plane as you're flying it. I think, you know, that's kind of, you know, what's going on here a little bit. Or a lot bit, probably.
Yeah. Yeah, thank you for that clarification, but I think the guidance, and I think that's what adds a little bit to the uncertainty that we're all facing, and how to move forward. And I think we're all on the very, very cautious side. So how do we best message that in a positive way to all those loved ones, families, staff, politicians, because we should all be speaking to them? I am very lucky. I have a governor who is very data-driven and has sought a lot of good help. And we have a lot of good data crunchers in the state of Washington, who Microsoft and Amazon, all those people have really been helpful. But how do we best message that, and how often should we do that? And what have you found to be helpful in this arena? Because we do not just want to say no. We want to say, we wish it were different, but this is the situation. So Jessica, what have you found helpful? We want to be the compassionate experts, because we talked about that last time. What kind of compassionate expert, how do you communicate your compassionate expertise in this question?
I mean, I think you're right. You used kind of a wish worry statement, right? That we use in like palliative medicine all the time, right? So I wish it were different, but I'm worried about walking down this path. And I think that frankly, a lot of this is about balancing the risks and the benefits of everything that we're doing and every decision that we're making. And sometimes that means going into a facility, whether it's mine or one that I'm just meeting with to try to help, and saying, we are here and we are all working together, and here's something another facility did that worked, that may not work, that may work well in your facility, and help them understand that this is all a balance, right? I feel like facilities in many cases are so used to marking boxes and hitting all of their requirements that when we expect them to A, get creative, and B, work kind of in the gray zone, it's hard for them. That's not what they are used to, because the regulations have always been so very strict, and this, as we've discussed, is really all based on guidance. And so I guess I would say, really being very clear about balancing all of our risks and helping everyone understand, this is the best that we can do right now. And for goodness sake, it might change in a few weeks when we have new data, but we have to make decisions about what we know now and what we know can be the best thing for our residents today.
I like the now and not making it a, it's the best thing now, and not kind of closing off the futures, like say hello, I don't know, Christmas 2021 or whatever. That's just such an unhelpful thing. Rich, what have you found to be helpful also as a CMO?
Well, I think it starts with transparency as to why we're so concerned. It's if we're not being straight around the risk to long-term care residents in nursing homes, if we're not being straight around how rapidly it can spread, or how many cases we have, or what our death rate has been. These are tough statistics. And if we're just trying to keep our heads down, and I know some have tried to do this because it's natural, it's normal, it's human, and it's also what our industry has done a lot in the past, just to try to keep our heads down because we're worried we're going to be blamed for something. But if we do that, then we can't be surprised when folks don't understand why we want to be extremely conservative. The only way we can get that level of understanding is by being very transparent as to why we're so worried and how bad this is and could be. So I think that's the most important thing, whether we're talking to stakeholders, politicians, regulators, or most importantly, family members, where we have disclosed each and everything, every statistic, no matter how scary it could be, to family members of loved ones in our centers, so that they know and they can share our concern and we can work together on these tough issues.
So the transparency and the sharing. Yeah. Alex, any wise words from you? I know you're not a clinician, but you're always very interested with us.
I could talk about it from a perspective of, being on calls and with members of Congress and their staff or CMS, and from that. And I actually have had a couple of family members call me about the situation in New York, which of course has been very interesting, and asking because they happen to see our AMDA's name appear on the major news outlets. So one thing I'll say, and Rich knows as well, he appeared on one of them, and there's been a number of AMDA members. Dr. Jeffrey Nichols was on CNN, I think at 4 o'clock Eastern, so a couple of hours ago. So the attention on nursing homes right now is unlike we've ever seen before. And of course, with attention comes a lot of responsibility. It could be bad, good, or a little bit of both. And I think it is that a little bit of both situation here. So the ability to not only be transparent, but to break through the noise and to be able to explain it in a very short, succinct amount of time. They're running news clips on, like I said, the major cable news networks, regular news. You are seeing stories in newspapers, whether it be local or national. And I think when family members are calling you, they are calling you because they have made up their mind. And unfortunately, we live in a world led by bubbles of social media, led by bubbles of whichever network you're working off of. And so I think they do have a lot of preconceived notions of what they already want to do. I think what you're telling them probably may be something antithetical to that. It may be agreeable to that. But I think you'll see both. But, the fact that nursing homes have been in such spotlight, the messaging becomes very, to me, probably a little bit different than, what we're used to. So I agree, it has to be clear, it has to be transparent, and it has to be succinct enough for people to kind of, understand. But at the same time, we also hear that we don't want to scare people, right? That it's like,
I know.
But that's the problem. If we are trying to not scare people, and we're therefore holding back on how scary it actually is, don't be surprised if they don't understand.
Right.
Yeah.
No, it's true.
The other side, if we scare them, then we do run the risk of people who really, really need to be in a long-term care or SNF setting not coming to one because they're so scared of being in a place that's such a hot spot.
Yeah, and one thing I'll say is that, different audiences, like with politicians and others, you really have to go down back to the basics. I mean, that's if they even understand what a nursing home or an assisted living facility is. I mean, you have to explain, how does a physician go in? How is it staffed? What is it? What's a skilled nursing facility? What's a nursing facility? What's an assisted living? What's a rehab center? You can't assume that they understand, or we know that they don't understand. Don't even assume that they do. So, a lot of times, you just have to, first of all, explain what you're dealing with, and then kind of, what you're doing about it. At least that's from my side of the world. On the ground, it may appear very different.
No, I agree. And also I agree with Jessica's point. I didn't mean to say otherwise, that we need to be reassuring about what we are doing and what's working, but also be transparent about how we still have a lot to learn about this virus, and it is devastating.
I think one of the things that may also be difficult in this setting is it's kind of hard to face a family and describe to them that you were successful when nothing happened. And that, it's like nothing is happening. So why are you still doing it? It's like nothing is happening because we were successful. I
live in Kansas.
Yeah. Yes.
Right? Like I live in Kansas. That's the problem that we're seeing in the Midwest. We flattened that curve very nicely.
Yeah.
And so now we have family members sneaking into facilities.
Right.
Yeah. Oh, that's scary. Yeah.
And it's not just family members. Going back to these CMS calls, one of the last calls I was on, they started talking about reopening the regular order surveys. Right now the surveys are infection control focused. So they started talking about, and the question really was about, there are many areas or parts of the country where COVID has not impacted facilities at all. And that was the statement that was made, which shocked me, because I don't know that you can make a statement that it hasn't impacted facilities at all. I think a more fair statement is that facilities have done a great job of focusing on what they need to do to keep the infection out. But that would be, I would put it, I don't work for CMS. So, that narrative, I think, is a little bit dangerous where we do see that. But that's what I'm talking about when I say that family members are defining their opinions on what's going on based on kind of those things they're hearing. And they are hearing things like, it's not impacting our area. I'll tell you, Maryland, Eastern Shore, Ocean City, resort towns opening up. They have nursing homes, and I don't know.
Well, I would like to see, are there any questions from the audience at this point? I see that somebody's still using rain ponchos, and my heart really goes out to you, because I have been there. Not lately though. It's a very bad space to be in, and I hate to see my staff that exposed. And I think it just goes to show to what length our staff is willing to go to protect residents. I hope you will. I think PPE supplies chains, and that's part of the problem. They are still severely disrupted. There is a great, and I will put that on the website, there's a great website that Christian Bergman sent me on organizations that are non-traditional PPE suppliers, and I'll make sure that gets onto the AMDA website for those folks of you who are still in the rain poncho stage, which I have been in the rain poncho stage, and it was very scary. Many people, and that's kind of where we failed in our infection control efforts early on when we were still in the rain poncho stage. All right, so well, thank you for participating in this discussion. I have learned much, and here are some pearls that I have learned while pondering over the May 18th guidance. I learned it is not a final rule, so it is a guidance. Really, it's not applicable if you're in the rain poncho or even in the non-traditional or extended use wear stage. This guidance, you will still be in the lowest phase if you're in that stage. However, there are ways to improve our patients' quality of life, and as medical directors, it's our responsibility to look for creative ways that serves patients in a compassionate way. And we talked about being outdoors. We talked about rooftops, parking lots, and really trying to get to a yes to connecting with your loved ones beyond just Skype and FaceTime. As far as communicating, I think we all agree that transparency and compassion and clear, giving clear understanding why we're doing this is very important. And I don't know whether I left anything out, but I'm sure I did leave a lot of things out. But as always, you have been really inspirational, and I feel very fortunate that we've been able to have this conversation. A very special thank you to our speakers for sharing their expertise and their wisdom today, and taking the time in your clearly packed schedule. We're looking forward to continue AMDA COVID-19 Grand Rounds Pearls from your callers as evidence and collective experience in COVID-19 is evolving. We want to give you the post-acute perspective and the long-term care perspective in an up-to-date and actionable fashion. Let us know which COVID-related questions for our space you seek answers to. in the care of our vulnerable patients. Thank you for all you do. Be well. Until next week. Bye-bye.
Bye, everybody.
Bye. Thank you, guys.
Thank you.